Hey guys, tonight we're doing something a little different. We're following one of the most dramatic career arcs in pharmaceutical history. A drug that started out as a miracle in a white coat, got handed around by a few too many people, made some truly catastrophic decisions, and ended up as one of the deadliest substances in modern existence. That drug is fentanyl. Not the kind your dentist mentions casually, while you're already panicking in the chair. I mean the whole story, the lab, the surgery suites, the pain clinics, the back alleys, and everything in between. So before you get comfortable, take a second to like the video and subscribe, but only if you actually enjoy what I do here. A very special, genuinely warm thank you to the viewer who suggested tonight's topic. You know who you are, and I want you to know that comments like yours are why this channel exists. Every suggestion shapes what we cover next, and I mean that. It means more than I can say. Also, and I'm quietly excited about this, we're now on Spotify. If you'd rather listen while doing absolutely nothing productive with your evening, the link is in the description. Now, dim those lights, pull up the covers, put on a fan if you've got one, that low white noise hum that tells your brain it's finally mercifully safe to shut off. Get horizontal. Settle in. And before we go any further, let me ask you a few things. Have you ever wondered how a drug invented in a Belgian laboratory in the 1960s ended up in 100 million emergency rooms, medicine cabinets and street corners? Did anyone actually think, at any point along the way, that this was going to be fine? What does it feel like to be a surgeon in 1965 thinking you've just discovered the future of pain management, completely unaware that the future has a very dark sense of humour? Could you have predicted, sitting in a chemistry lab in Brussels, that the molecule you were carefully synthesizing would one day be laced into counterfeit pills and sold outside a high school? And what does it say about us, about the entire medical, pharmaceutical and regulatory system, that we watched this happen in slow motion for decades and still couldn't quite stop it? Congratulations! You've just woken up in 1960 in a small but very ambitious pharmaceutical laboratory in Brussels, Belgium. A chemist named Paul Janssen is about to synthesize something 10,000 times stronger than morphine. He thinks he's solving a problem. He has no idea he's starting one. It begins, as most catastrophes do, with a very smart person trying to do something genuinely good. Paul Janssen was a Belgian pharmacologist born in 1926, the son of a doctor, who by his mid-30s had already developed more approved pharmaceutical drugs than most entire companies would produce in a lifetime. He wasn't reckless. He wasn't sinister. He was, by almost every account, a dedicated scientist who wanted to reduce human suffering. And in 1960, working out of his own small research company, Janssen Pharmaceutica, he succeeded spectacularly, dangerously, and permanently. He synthesized fentanyl, a synthetic opioid he designed to be faster acting and more controllable than morphine. It worked beautifully and it worked terrifyingly well. The molecule he built that day would go on to reshape surgery, rewrite the rules of pain management, and eventually become the leading cause of drug overdose deaths in the United States. Paul Janssen wanted to make people hurt less. He did, for a while. Then things went sideways in ways that would take decades to fully understand. Here is what you have to appreciate about Paul Janssen, because this story does not work without him. He was not a fringe character. He was not a mad scientist in a basement. He was one of the most respected pharmacologists of the 20th century, a man who would go on to develop over 80 approved pharmaceutical compounds across his career, including antipsychotics, antifungals, and antiparasitic medications that are still used today. He received the highest scientific honours Belgium could bestow. He corresponded with the Chinese government about pharmaceutical development in the 1980s. He was, by any reasonable measure, a figure of establishment legitimacy, which is part of what makes fentanyl's trajectory so disorienting when you sit with it. You're not looking at a drug created by someone cutting corners, chasing profit, or ignoring safety. You're looking at a drug created with genuine precision and genuine purpose by someone who understood exactly what it was, and who, by most accounts, spent the rest of his life watching it be used in ways he never intended, with consequences he could not have fully predicted. When Janssen synthesized fentanyl in 1960, he was working within a specific scientific tradition, the search for better opioids. Morphine had been the gold standard of pain management since the early 19th century, but it came with significant limitations. It was slow to reach the brain, meaning pain relief could take 20 minutes or more. It accumulated in the body's fat tissue, meaning the effects could linger long after a patient needed to be alert, and its side effects, nausea, vomiting, respiratory depression, were difficult to manage with precision. Janssen's goal was to find a compound that worked faster, cleared the body more cleanly, and could be controlled more precisely during the specific time-limited window of surgical anesthesia. Fentanyl did all of this. It reached the brain within minutes. It metabolized quickly. And it was so potent in such small quantities that doses could be calibrated with a precision that morphine simply did not allow. In the context of 1960 surgical medicine, this was a genuine breakthrough. The fact that this same potency, this same speed, this same efficiency would later make fentanyl extraordinarily dangerous outside a controlled clinical environment was not, at the time of synthesis, the foreground of the conversation. It was the background, the kind of background detail that takes decades to become the entire story. Paul Janssen died in 2003, 4 years before fentanyl became a household name for the worst possible reasons. Whether he saw what was coming, whether he worried about it, whether he felt the particular weight of having created something that could not be uncreated, we don't fully know. What we know is that the molecule he built in a small Belgian lab in 1960 is still here, still potent, still spreading, still in the right hands, saving lives, and in the wrong ones, ending them. He made something that worked too well, and the world has been catching up ever since. Before we go any further, let's talk about what fentanyl actually is, because there's a lot of breathless coverage and not enough calm explanation. Fentanyl is a synthetic opioid, which means it was built in a laboratory rather than extracted from the opium poppy the way morphine and heroin are. It works by binding to opioid receptors in the brain, the same receptors that morphine, heroin, and even your body's own natural endorphins bind to. But it does so with extraordinary efficiency. It is, depending on how you measure it, somewhere between 50 and 100 times more potent than morphine by weight. That doesn't mean it makes you 50 to 100 times higher. It means an almost unimaginably small quantity produces the same effect. A dose of fentanyl that would fit on the tip of a pencil can be lethal to a person with no tolerance. It crosses the blood-brain barrier faster than most opioids, which means it acts quickly, wears off relatively quickly, and leaves very little room for error. In a controlled surgical setting, with dosing equipment and a trained anesthesiologist, that speed is a gift. On a street corner with no idea what you're actually consuming, it is something else entirely. Let's stay with the science for a moment, because understanding how fentanyl works in the body is genuinely important to understanding why it kills so efficiently when things go wrong. Your brain has what are called opioid receptors, specifically the mu-opioid receptors, which are the main target of fentanyl. These receptors, when activated, produce a cascade of effects: pain relief, euphoria, slowed breathing, and a kind of profound physical calm that has made opioids the backbone of pain management for over a century. Your body makes its own molecules that bind to these receptors, endorphins, enkephalins, but they are mild by comparison. They're the body's way of saying everything is manageable. Fentanyl is the body's way of saying nothing matters anymore, and it says it very loudly. Now imagine those receptors as a series of doors in the brain. Morphine picks the lock, fentanyl kicks it open. The speed of entry matters enormously because the faster a drug reaches peak concentration in the brain, the more intensely it is experienced, and the more powerfully it suppresses the brain's drive to breathe. Respiratory depression, the slowing and eventual cessation of breathing, is what kills people in opioid overdoses. Not heart failure, not seizure. The brain simply stops issuing the automatic instruction to inhale. You become very relaxed, then more relaxed, then still. In the presence of fentanyl, this process can happen in minutes. This is why tolerance matters so much in this story. A person who uses opioids regularly develops a degree of tolerance. Their opioid receptors adapt. The respiratory suppression becomes less dramatic, and they can tolerate doses that would be fatal to someone without that history. A person with no tolerance, someone who has never used opioids, or who has been abstinent for a period and lost their tolerance, has essentially no buffer. The same dose that a person with high tolerance handles without crisis can kill a naive user in the time it takes to scroll through your phone. And because illicitly manufactured fentanyl is not dosed with pharmaceutical precision, the content of any given pill or powder can vary enormously. The tolerance that kept you safe yesterday tells you nothing about what is in your supply today. This is not panic. This is pharmacology. And it is the foundation of everything that follows. For the first decade or so of its existence, fentanyl lived a quiet, useful, highly controlled life inside the operating room, and frankly, it was doing a wonderful job. Introduced into clinical use in Europe in the early 1960s and in the United States in 1968 under the brand name Sublimaze, fentanyl transformed the way surgeons and anesthesiologists managed pain during procedures. Before fentanyl, anesthesia was a balancing act between keeping a patient unconscious and not accidentally killing them with the drugs required to do so. Morphine, while effective, was slow to act and slow to clear the body, meaning patients could wake up groggy and in pain for hours after a procedure. Fentanyl, by contrast, was fast. It could be precisely dosed, it left the system relatively quickly, and it could be combined with other agents to create what was called balanced anesthesia, a carefully layered sedation that gave surgeons the still, pain-free environment they needed while giving patients a cleaner, faster recovery. For nearly a decade, fentanyl barely left the hospital. It was a surgeon's drug, a procedure drug, a thing that happened to you under fluorescent lights, while someone in scrubs counted backwards to make sure you were out. It had no street reputation. Nobody was asking for it by name. And the anesthesiologists who used it every day thought of it the way a carpenter thinks of a good nail gun, an excellent purpose-built tool that belonged in a specific professional context and nowhere else. Think about what this means for a moment. There is a whole generation of operating rooms in the 1960s and 1970s where fentanyl is doing exactly what it was designed to do, exactly as intended, with outcomes that are measurably better than what came before. Patients wake up clearer, recovery times improve. The precise control that fentanyl offers over the depth and duration of sedation gives anesthesiologists a level of finesse that genuinely changes what surgeries are possible. Open heart procedures, long spinal operations, complex abdominal surgeries, all of these benefit from a drug that can be dialed up and dialed back with something approaching precision. There is a version of this story where fentanyl stays here, in this brightly lit room, doing this job, and nothing else ever happens. It is a short story. In that version, Paul Janssen's molecule is a respectable footnote in the history of anesthesiology, a clever compound that improved surgical outcomes and was slowly superseded by something even better. No crisis, no epidemic, no headlines, just a technical improvement in a technical field noted by professionals, invisible to everyone else. That is not the story. But it is worth pausing on, because in the early years, fentanyl really was just medicine. The anesthesiologist drawing it into a syringe in 1972 was not participating in the first chapter of a public health disaster. They were doing their job well. The drug was controlled, the setting was clinical, the dosing was precise, and the patient was monitored continuously by people trained specifically to manage the risks involved. The lesson here, and it is a lesson the story will return to repeatedly, is that context is almost everything with fentanyl. In the right hands, with the right equipment, in the right setting, it is a tool of genuine mercy. Take it out of that context. Remove the monitoring, the precision, the trained oversight, and the same molecule that helped your grandmother through a hip replacement become something no one wants to encounter unprepared. The operating room was fentanyl's natural habitat. The problem, as we will see, is that natural habitats have a way of expanding. If fentanyl's first act was as a quiet, well-behaved surgical tool, its second act began in 1990, when the FDA approved a small adhesive patch called Duragesic, and everything got considerably more complicated. Developed by Janssen Pharmaceutica and marketed by Alza Corporation, the fentanyl transdermal patch was genuinely innovative. It was designed for patients with chronic, severe pain, primarily cancer patients who needed round-the-clock relief without the disruption of repeated injections or the unpredictability of oral medications. The patch delivered a slow, steady dose of fentanyl through the skin over 72 hours. For patients in genuine, unrelenting agony, it was a meaningful improvement in quality of life. But the patch also created something new in the opioid world, a portable, wearable, long-duration delivery system for one of the most potent substances on Earth. It could be cut, manipulated, heated to release more medication faster, or simply worn by someone for whom it was never intended. It was, in the language of pharmacology, a controlled-release formulation. In the language of what was about to happen next, it was an accident waiting for a decade to unfold. To be fair, the patch was, in its intended context, a remarkable piece of medical engineering. Before Duragesic, a cancer patient in severe pain had limited options. Oral morphine, which required careful timing and could produce peaks and troughs of relief and suffering. Intravenous or subcutaneous infusions, which required medical equipment and usually hospital or hospice settings, or inadequate management with shorter-acting medications that left gaps in coverage that anyone who has ever watched someone suffer through them will tell you were not acceptable. The patch smoothed all of that out. A steady, predictable delivery of medication over 3 days, changed at regular intervals, with no injection required. For the patient it was designed for, someone with cancer, with legitimate and documented severe pain, managed by a physician who knew their history, it was genuinely useful. The problem started, as these problems often do, at the edges of the intended population. By the mid-1990s, the prescribing culture around opioids was shifting. The idea that pain was undertreated in America, genuinely true in some contexts, aggressively amplified in others by pharmaceutical marketing, created pressure on physicians to reach for stronger tools. Fentanyl patches began appearing in prescriptions for back pain, neuropathic pain, fibromyalgia, conditions that were real and painful but that the patch's original approval had not been designed to cover. And then there was the manipulation problem. A Duragesic patch in its original gel formulation contained a reservoir of fentanyl solution. If you cut the patch open, you could extract that gel. You could heat the patch to accelerate delivery. You could wear multiple patches simultaneously. None of these things were difficult to figure out. The knowledge spread quickly through the networks where such knowledge always spreads quickly. There was also the disposal issue. A used fentanyl patch, after its 72 hours of prescribed use, still contained a meaningful amount of residual medication. The instructions for disposal were, in the early years, not particularly emphatic. Patches were ending up in household trash. They were being retrieved. In some cases, children were being harmed by coming into contact with discarded patches. The FDA received reports. Warnings were issued. Formulations were eventually changed. But the timeline between problem and fix was measured in years, and years in this story are never free. To understand how fentanyl ended up everywhere, you have to understand the world it was born into, a world that was, by the 1990s, being actively reshaped by the idea that doctors had been undertreating pain for decades, and that this was a moral failure requiring urgent correction. The campaign to treat pain as a fifth vital sign, pushed hard by pharmaceutical companies and adopted enthusiastically by medical institutions, changed prescribing culture in ways that are still being untangled today. OxyContin arrived in 1996, backed by Purdue Pharma's now infamous sales army, and a set of claims about its addiction potential that were, to put it charitably, not accurate. But OxyContin was only the loudest part of a much larger shift. Through the late 90s and early 2000s, opioid prescriptions of all kinds surged. Fentanyl patches, originally restricted to cancer pain, began appearing in prescriptions for back pain, fibromyalgia, and other chronic conditions. The reasoning was, not always wrong, chronic pain is real, undertreated pain is genuinely harmful, but the guardrails were gone, the oversight was thin, and the pharmaceutical industry had every financial incentive to keep the momentum going. You have to imagine what the prescribing culture felt like from inside a doctor's office in, say, 1998. You have pharmaceutical representatives arriving with glossy materials telling you that modern opioid formulations are far safer than old-school morphine. You have medical conferences with sessions on the undertreatment of chronic pain. You have pain management specialists, a newly prominent specialty, advocating strongly for aggressive opioid treatment. And you have, sitting across the desk from you, a patient who is in real pain, who has tried other things, and who is looking at you for help. The drug that might help them is available, it is FDA approved, and the people selling it have told you it won't cause the problems you might be worried about. Some physicians were credulous when they shouldn't have been. Some were deliberately misled. Some were negligent. And some found themselves, a decade later, looking at patient panels full of people dependent on drugs that no longer adequately controlled their pain but that they could not safely stop taking. The distinction between these categories matters, but the outcome was the same, a river of opioid prescriptions flowing into communities across the country. Fentanyl patches followed OxyContin into this expanded market. By 2005, Duragesic was generating over $2 billion a year in revenue. It was being prescribed to patients who were not dying of cancer, for pain conditions whose relationship to the drug's risk profile was, to put it gently, unclear. And it was sitting in medicine cabinets in millions of American homes, a potent, portable, partially understood tool, waiting for the second act of a story that was already well underway. The early warning, signs about fentanyl patches appeared before most people were paying attention, which is, historically speaking, exactly how warning signs work. By the late 1990s, reports began surfacing in emergency rooms and medical journals of people misusing the transdermal patches in ways their manufacturers had not intended, or at least not publicly anticipated. Patches were being worn by people for whom they had not been prescribed. They were being cut open so the gel inside could be extracted and injected. They were being heated, taped over a light bulb, or pressed between warm hands to accelerate the release of medication. In some cases, used patches found in hospital trash were being retrieved because even a spent patch still contained a meaningful amount of fentanyl. Medical examiners began noting fentanyl-related deaths, that did not fit the profile of surgical or cancer patients. The drug was seeping out of its controlled context and into a far messier, far less supervised one. And here is the grim specificity of what those early deaths looked like. The people dying were not in many cases people with long histories of substance use. Some were teenagers who had found patches in a parent's or grandparent's medicine cabinet. Some were adults with opioid tolerance who had underestimated the difference between fentanyl and the drugs they were accustomed to. Some were people who had worn a patch and simply fallen asleep and not woken up, because unlike an oral medication you swallow, a patch on your skin keeps delivering medication as you sleep, as you drink, as your body temperature rises in a warm bath. The interactions between fentanyl patches and heat became a specific category of tragedy. Heating pads, hot tubs, fevers. Any source of elevated skin temperature could dramatically accelerate absorption and turn a prescribed dose into a fatal one. The pharmaceutical company and the FDA responded eventually. Black box warnings were strengthened. The prescribing indication was clarified to emphasize that the patch was for opioid-tolerant patients only. Tamper-resistant reformulations were developed. The gel reservoir patches that could be cut open and extracted were phased out in favor of matrix formulations where the fentanyl was embedded in the adhesive layer itself, making extraction significantly more difficult. But here is the thing about warning labels and reformulations. They help at the margins. They raise the barrier slightly. They reduce some categories of accidental harm. They do not reach the person who has already figured out how to work around the original design. They do not retrieve the information that has already spread, and they do not address the more fundamental question that was, by this point, becoming impossible to ignore, which was not how people were misusing fentanyl patches, but why, in the first place, there were enough fentanyl patches in enough homes to make misuse a statistical certainty. Here is where the story takes a turn that would have seemed like science fiction in 1960, when Paul Janssen first built his molecule in Brussels. Fentanyl is not one drug, it is the center of a chemical family. Because its structure is synthetic and relatively well understood, it can be modified, a carbon here, a hydrogen there, to produce dozens of related compounds called fentanyl analogues. Some of these analogues were developed legitimately, as medical researchers explored variations on fentanyl structure for potential clinical use. So fentanyl, carfentanil, and alfentanil are all fentanyl analogues developed in pharmaceutical settings, each with slightly different potency and duration profiles. But the same chemistry that allows a legitimate researcher to explore these modifications allows anyone with sufficient knowledge and access to precursor chemicals to do the same. And in the early 1980s someone did. Alpha-methylfentanyl, a fentanyl analogue not approved for any medical use, began appearing on the streets of California. It was called China White. It was extraordinarily dangerous, and it was made entirely in clandestine labs by people who had read the right chemistry papers. The story of how those chemistry papers became a street drug is worth sitting with. The academic literature on fentanyl analogues was not secret. It had been published in peer-reviewed journals throughout the 1970s as researchers systematically explored what modifications to Janssen's original molecule produced what effects. The publications were thorough, detailed, and publicly available in any university library. They were written for pharmacologists. They were read eventually by people with very different intentions. The person or people responsible for the California analog deaths were never conclusively identified. What investigators did establish, through careful forensic chemistry, was that the compounds being produced were of genuinely sophisticated quality, not crude approximations but precise syntheses that implied real chemical knowledge and real laboratory capability. This was not a kitchen operation. This was someone who understood what they were doing, who understood the pharmacological implications of what they were making, and who proceeded anyway. The regulatory response was to add fentanyl analogues to Schedule 1 of the Controlled Substances Act, a legal designation meaning no accepted medical use and high potential for abuse. This was done, and it helped, and it did not stop anything. Because the chemistry is the chemistry. Scheduling a compound makes it illegal to possess and manufacture without authorization. It does not make it impossible to synthesize. And the critical insight that you could modify the fentanyl molecule to produce a drug more potent than anything on the controlled market, that this drug could be made in a small space with purchased chemicals, and that it could be distributed in quantities so small as to be nearly invisible, was now part of the permanent record of what was chemically possible. The genie, to use an overused metaphor that is nonetheless accurate here, was not going back in the bottle. The bottle had been published in the Journal of Medicinal Chemistry. The California deaths of the early 1980s are a piece of history that should have been much louder than it was. Between 1979 and 1988, more than 100 people died in California from what investigators eventually identified as illicitly manufactured fentanyl analogues, substances sold as heroin but far more potent and far less forgiving. The victims were heroin users who had no way of knowing what they were actually buying. They used the same amount they would use for their usual supply. That amount was lethal. The investigation that followed was sophisticated for its time. Investigators worked backwards from the deaths to the chemistry to the clandestine lab producing the drug. But the problem they identified, that synthetic opioids could be manufactured in small mobile labs and distributed in quantities so tiny they were essentially invisible, was a problem without an obvious solution. Picture yourself as a DEA investigator in 1983, standing in a Los Angeles emergency room, looking at a tox screen that shows fentanyl in someone who definitely did not come into contact with a hospital. You have, at this point, a mystery and a corpse. What you do not have is a playbook. Nobody has been here before. Heroin overdoses are not new. Fentanyl overdoses in heroin users are new. The infrastructure for identifying the compound, for distinguishing it from heroin in a standard toxicological screen, was not yet standard. Many of the early California deaths were initially attributed to heroin, before more specific testing identified what was actually present. The forensic chemist who became central to the investigation, Gary Henderson of the University of California, Davis, coined the term designer drugs to describe these novel synthetic compounds, substances engineered to produce drug-like effects, while technically evading the legal definitions of existing controlled substances. It was an accurate term, and it described a category of problem that would grow enormously over the following decades. When the California outbreak eventually subsided, the suspected lab or labs apparently stopped production. For reasons that were never fully established, there was a temptation to treat it as a contained historical event, a strange chapter, an anomaly. What it actually was, in retrospect, was a proof of concept. It demonstrated that illicitly manufactured synthetic opioids could appear in a drug supply, kill people before anyone understood what was happening, evade standard detection, and largely disappear before law enforcement could fully respond. It demonstrated all of this in the 1980s 4 decades before. Fentanyl became the primary driver of overdose deaths in the United States. The lesson was available. It was not widely learned. This is the kind of story that sounds like it was made up for a television drama, except that it happened. It was real. And it is one of the more alarming demonstrations of what happens when a highly controlled substance meets a charismatic, reckless, and well-connected person. In 2002, a Beverly Hills anesthesiologist was convicted of illegally dispensing fentanyl and other controlled substances to wealthy clients seeking what was sometimes called twilight sedation, a medical-grade altered state supervised by someone with a license in a reassuring manner. Cases like this one, and there were others in the late 90s and early 2000s, illustrated something important and troubling. that fentanyl's prestige as a legitimate medical compound gave it a kind of cover that street drugs lacked. People who would never have touched heroin would accept fentanyl from a doctor. The white coat laundered the danger. This is not a new dynamic in the history of medicine, but fentanyl made it particularly sharp. There is a category of harm that is harder to see because it is wrapped in clinical legitimacy. It happens in nice offices, in spa-like treatment rooms, in concierge practices where the barrier to entry is a credit card rather than a needle. The patients are not, in the cultural imagination, drug users. They are people seeking comfort, seeking escape from anxiety or insomnia, seeking the particular relief that only something truly pharmaceutical can provide. And the person providing it has a medical degree on the wall and a very confident manner. These cases represented only a small fraction of fentanyl-related harm in this period, but they pointed to something structurally important, that the controls around fentanyl, the DEA scheduling, the prescription requirements, the hospital formulary restrictions were controls on paper, and the actual security of any controlled substance is only as strong as the integrity and oversight of the humans in the chain of custody. Remove the integrity, reduce the oversight, and the substance moves. It always moves. The broader lesson here is about the porousness of the line between medical and recreational use of powerful opioids, a line that the prescribing boom of the 90s had already made much less clear. When a drug is available in millions of homes and hundreds of thousands of clinical settings, the idea that it can be completely contained by the categories on the prescription pad becomes increasingly theoretical. Fentanyl was officially a medicine. Unofficially, it was becoming something else, and no one had quite decided what to do about the gap. It is one of the grimmer features of American public life that sometimes the only thing that makes a crisis visible to a broad audience is the death of someone famous. Fentanyl killed Prince on April 21st, 2016, at his home compound, Paisley Park in Minnesota. He was 57 years old. He had no known history of substance abuse, but he had a well-documented history of chronic hip pain, the result of decades of performing, often in heels, on hard stages. Investigators found fentanyl in his system and counterfeit Vicodin pills containing fentanyl in his home. He had, by all accounts, not known what was in the pills he was taking. He had been trying to manage pain that was real and had been given something that killed him. Tom Petty died in October 2017 from an accidental overdose of a mixture of drugs that included fentanyl. McMillan died in September 2018 from a combination of fentanyl, cocaine, and alcohol. Each death added a name and a face to a crisis that statistics alone had struggled to make personal. The Prince case, specifically, became a kind of Rorschach test for every argument in the opioid debate, for those focused on, or, prescription drug abuse. It was a story about a system that failed a patient in pain, about the difficulty of obtaining legitimate medical care for chronic conditions, about the void that failure leaves, about what people do when the official channels are not working. For those focused on illicit supply, it was an early, prominent demonstration of the counterfeit pill problem, of the specific danger of purchasing medication outside the regulated supply chain in an era when fentanyl was being pressed into tablets that looked exactly like branded pharmaceuticals. Both readings were correct. Prince had legitimate pain. The medical system around him had failed in various ways to address it adequately. He had turned to sources outside the official supply chain, and those sources had provided him with something that was not what it appeared to be. Every element of that story, the undertreated pain, the institutional failure, the counterfeit supply, the lethal content would recur tens of thousands of times in less famous circumstances over the years that followed. The celebrity deaths did something important and something troubling simultaneously. They made fentanyl visible. They put the word in headlines, in conversations, in the vocabulary of people who had never had reason to know it before. but they also, by virtue of the particular lives involved, slightly distorted the picture of who fentanyl was killing. The 57-year-old rock legend dying at Paisley Park was a story. The 24-year-old in rural West Virginia dying in a trailer was a statistic. Both were fentanyl deaths. The statistic was happening 10,000 times more often. The story of how illicitly manufactured fentanyl went from a niche, domestic problem to a continental catastrophe has a specific and traceable inflection point, and it runs through Mexico. By the mid-2010s, Mexican drug cartels, primarily the Sinaloa cartel and the Jalisco New Generation cartel, recognized that fentanyl represented an enormous economic opportunity. A kilogram of heroin required a significant amount of land, labor, and time. Opium poppies need to be grown, harvested, and processed. A kilogram of fentanyl could be synthesized in a laboratory from chemical precursors, most of which were being imported from China, and could produce vastly more doses than a comparable weight of heroin. The math was straightforwardly attractive from a criminal business perspective. The cartels began investing in fentanyl production at scale. Labs, chemists, distribution networks, and eventually pill presses that could produce counterfeit versions of branded medications loaded with fentanyl. These pills were visually indistinguishable from the real thing. They were sold in exactly the same context as diverted prescription drugs, and they were almost never dosed consistently. Think about what this shift represents in the history of the drug trade. For most of the 20th century, the opioid supply chain began with a plant. Opium poppies, grown in Afghanistan, Myanmar, Mexico, Colombia, required land, agricultural labor, seasonal harvests, and a complex processing chain to convert raw opium into morphine and then into heroin. This supply chain was visible from the air, vulnerable to crop eradication, dependent on geography, and constrained by the physical realities of agriculture. A drought could reduce supply. A successful interdiction operation could seize a meaningful portion of the product. The economics of the supply chain created a floor under prices and a ceiling over production. Fentanyl removed all of that. A clandestine fentanyl laboratory can operate anywhere there is electricity, a water source, and access to precursor chemicals. It produces no crop that can be photographed by satellite. Its output is measured in grams rather than tons. A single kilogram of fentanyl, a quantity that fits in a small bag and can be shipped in a standard package, can produce approximately 500,000 fatal doses. This is not a metaphor for potency. This is the arithmetic of why fentanyl changed the economics of the illicit drug trade more fundamentally than anything since the introduction of crack cocaine in the 1980s. The cartels that made this shift did so with the same business logic. They applied to every other product: reduce costs, increase margins, expand market. Fentanyl was cheaper to produce, more profitable per unit, and more addictive than heroin, which meant better customer retention in the grotesque vocabulary of drug market economics. The human cost of this calculation was not a consideration. It was, at best, an externality. If the cartels were the manufacturers of the fentanyl crisis, China was, for a significant period, the supplier of its raw materials. The chemical precursors needed to synthesize fentanyl, compounds like 4-ANPP, NPP, and various piperidine derivatives, were being produced legally by Chinese chemical companies and exported, sometimes with minimal oversight, to buyers in Mexico and, for a period, directly to buyers in the United States. The DEA and international law enforcement were aware of this supply chain and worked to address it, but the challenge was structural. The precursor chemicals were not themselves scheduled as controlled substances in many jurisdictions, which meant their production and export was technically legal, even when their end use was obvious. China took significant steps to address the problem in 2019. scheduling fentanyl and all its analogues under domestic law and cutting off a significant portion of the direct-to-consumer pipeline. But by that point, the cartels had adapted. The precursor chemical problem is one of those issues that looks, from the outside, like it should be straightforward to solve and is, in practice, extraordinarily difficult. There are many legitimate uses for the chemicals required to make fentanyl. They're used in the production of legal pharmaceuticals, in industrial applications, in research settings. The same compound that a Mexican cartel purchases to make fentanyl might also be purchased, in slightly different quantities, by a pharmaceutical manufacturer making a legitimate medication. Restricting the chemicals broadly would harm legitimate industry. Restricting them narrowly requires precise intelligence about which buyers are diverting them to illicit use, intelligence that is difficult to gather and even more difficult to act on across international jurisdictions. When China announced its 2019 scheduling decision, it was a genuinely significant step. The volume of precursors flowing directly from Chinese suppliers to American buyers dropped dramatically. Overdose deaths, which had been rising steeply, did not immediately follow because the cartels, facing a new supply challenge, did not simply stop. They diversified their precursor sources, developed new synthesis routes, using different starting chemicals, and generally demonstrated that anyone who assumed that disrupting one link in a global chemical supply chain would end illicit fentanyl production had underestimated the adaptability of organizations that had decades of experience evading exactly this kind of pressure. The current situation involves precursor chemicals sourced from multiple countries, synthesis routes that change frequently, and a cat-and-mouse dynamic between illicit chemists and international regulators that shows no signs of resolution. The molecule at the centre of this system was designed in a Belgian laboratory in 1960. The laboratory in which it is now most often made looks very different from Janssen's workspace. The chemistry at its core is the same. In the autumn of 2022, images began circulating on social media and in news coverage of fentanyl pills in bright candy-like colours: pink, blue, yellow, green, sometimes swirled together. The DEA issued warnings, politicians held press conferences. The phrase rainbow fentanyl entered public discourse, alongside fears that drug traffickers were deliberately targeting children by making their product look like candy. The concern was not entirely unfounded. Brightly coloured counterfeit pills are a public health issue, but the specific fear that cartels were poisoning Halloween candy or handing out drug-laced sweets to children who didn't know what they were getting was not supported by evidence. What the rainbow fentanyl story illustrated, beyond the pharmacological facts, was the degree to which fentanyl had become a political object as much as a public health one. Its dangers were real, and had been real for years before the coloured pills arrived. But the colours made for better pictures, and better pictures make for louder coverage. The drug panic is a recurring feature of American history, and it is worth understanding its structure, because it tends to produce both genuine insight and significant distortion simultaneously. The genuine insight in the 2022 rainbow fentanyl coverage was this: colourful counterfeit pills are designed to be attractive. They are being marketed to younger users, and the fentanyl crisis is not only a crisis of people with opioid use disorder, it increasingly involves accidental ingestion by people who believe they are taking something else entirely. These points were valid. They were worth making. They reflected a real shift in how illicit fentanyl was being packaged and sold. The distortion was the framing that positioned random children as the primary risk population, that the central danger was the unsuspecting kindergartner offered a brightly coloured tablet by a stranger. This framing, however emotionally resonant, directed attention and resources toward a scenario that was not, in fact, the dominant source of fentanyl deaths. The dominant source remained the same as it had been: People who were knowingly obtaining drugs from unregulated sources and who had no reliable way of knowing what those drugs actually contained. Redirecting the story toward a hypothetical child victim made it easier to tell politically and harder to address practically. Drug panics tend to generate legislation more easily than they generate help, and legislation produced by panic tends to emphasize criminalization over treatment. The rainbow fentanyl moment was, in this sense, a familiar chapter in an old book. The specific content was new, the shape of the response was not. In the face of a drug that can kill in minutes, the medical and public health communities turned to a molecule that had existed since 1961, Naloxone. Marketed as Narcan, Naloxone is an opioid antagonist. It binds to the same receptors that opioids use, blocks them, and can reverse an overdose in seconds. It is, in the right circumstances, a near miraculous intervention. A person who is blue, unresponsive, and not breathing can receive a naloxone injection or nasal spray and be awake and breathing within 2 to 5 minutes. But fentanyl's potency created a new challenge. Standard doses of naloxone that were effective against heroin overdoses sometimes required multiple administrations to fully reverse a fentanyl overdose, because fentanyl binds so tightly to opioid receptors. The gap between collapse and irreversible brain damage is measured in minutes, and the gap between the dose needed to reverse heroin and the dose needed to reverse fentanyl became a matter of ongoing clinical adjustment. Here is how a fentanyl reversal looks in practice, because the clinical description does not quite capture what it actually means to watch it happen. Someone is found unconscious, in a bathroom, on a sidewalk, in a car. Their breathing is barely perceptible. Their lips have a bluish tint. If they are not given naloxone in the next few minutes, they will sustain brain damage from oxygen deprivation. If they are not given it in the next several minutes, they will die. The person administering the naloxone, a bystander, a police officer, a paramedic, administers it nasally or by injection, and within 2 to 5 minutes the person wakes up. Not gently. Opioid reversal is abrupt and uncomfortable. The person goes from unconscious to awake and confused, sometimes angry, sometimes terrified, sometimes not understanding what has just happened to them. The expansion of naloxone access, from a hospital-only medication to one available over the counter at pharmacies, distributed free at needle exchanges and community centres, carried in the glove compartments of police cruisers across the country, is one of the genuine public health successes of the fentanyl era. It has saved an enormous number of lives. The debate over whether providing naloxone freely encourages drug use has been studied repeatedly and answered consistently. It does not. It prevents deaths. The people arguing otherwise are, in the kindest interpretation, more concerned with the moral message than with the body count. And yet, naloxone is a reversal, not a cure. It addresses the immediate physiological crisis without addressing any of the conditions, pain, addiction, trauma, poverty, isolation that produced the crisis. The person who is revived by naloxone is alive, which is necessary for anything else to happen. What happens next determines whether that survival becomes recovery. That part is harder and slower and less dramatic, and it has received considerably less attention. To understand what the fentanyl crisis looks like from the inside, it helps to sit briefly in an emergency room at around 2 a.m. in a mid-sized American city around 2017. The paramedics bring in someone, young usually, sometimes very young, found unresponsive by a friend or a passerby. They are not breathing adequately, or they are barely breathing, with the slow, deep respirations that emergency responders call a tell. The nurses move quickly. Naloxone is administered. Usually, not always, but usually the patient wakes up, often confused, sometimes angry, occasionally grateful. And then the harder conversation begins. What happens next? Because naloxone wears off faster than fentanyl. A patient who is revived and then discharges themselves against medical advice may go right back to the same substance that nearly killed them and may die in the parking lot of the hospital. Emergency physicians in the fentanyl years developed a particular vocabulary for the experience of working in the middle of an epidemic that the healthcare system was not designed for. They talked about the door, the figurative door of the ER that kept swinging open with the same presentations night after night. They talked about the futility of treating the acute event when the chronic condition driving it remained completely unaddressed. They talked about the patients they had reversed 3 times, 5 times, a dozen times, and the profound ethical and emotional complexity of continuing to pour resources into acute intervention while the structural problems that produced the need for that intervention remained unchanged. This is not a criticism of emergency medicine. It is a description of what it looks like when a chronic, systemic, social structural problem presents itself at the door of a system designed for acute, individual biomedical problems. Emergency departments are extraordinary at the thing they do. They stabilize people who are about to die, and they do it at any hour for anyone, without requiring insurance or prior authorization or a scheduled appointment. What they are not designed to do is address the reasons someone is about to die for the 3rd time from the same cause in the same building. The physicians who work those shifts did not sign up for a public health crisis. They signed up to practice emergency medicine. The crisis came to them, and they treated it with the tools they had: Naloxone, monitoring, brief intervention, referral to treatment resources that were, very often, either unavailable or inaccessible to the people being referred to them. They kept people alive. They did it heroically, repeatedly, and at significant personal psychological cost. And then the door swung open again. There is a moment in every public health crisis where the numbers become so large they stop feeling real, and the fentanyl crisis passed that point somewhere around 2017. In that year, synthetic opioids, primarily fentanyl, overtook prescription opioids, and heroin combined as the leading cause of drug overdose deaths in the United States. In 2020, the first full year of the COVID-19 pandemic, overdose deaths surpassed 93,000, the highest ever recorded in a single year. More than 60% of those deaths involved synthetic opioids. By 2021, the number exceeded 100,000. To put that in context, more Americans died of drug overdoses in 2021 than died in the entire Vietnam War. More than died in car accidents. More than died of gun violence. The deaths were not evenly distributed. They fell hardest on communities already battered by economic dislocation, on rural areas with fewer treatment resources, on people who had lost the social scaffolding that makes recovery possible. The graph of opioid overdose deaths in the United States from 1990 to 2022 describes what epidemiologists call 3 waves, and the shape of it should make anyone who looks at it sit quietly for a moment. The first wave, from the late 90s to approximately 2010, tracks the rise of prescription opioid deaths: OxyContin, Vicodin, fentanyl patches, hydrocodone. It rises steadily, driven by the prescribing boom, and it kills tens of thousands of people. The second wave, beginning around 2010, tracks the rise of heroin deaths. Many people who had become dependent on prescription opioids, cut off from their supply as prescribing restrictions tightened, turned to heroin, cheaper, more available, and in many markets stronger. The second wave is steeper. The third wave begins around 2013 and does not stop. It is the fentanyl wave, and its slope is nearly vertical by 2020. The third wave is steeper than the first 2 combined. It is driven not by prescription drugs, and not entirely by heroin, but by illicitly manufactured fentanyl, pressed into counterfeit pills, mixed into heroin and cocaine and methamphetamine supplies, sold in forms that no one buying them can identify with any confidence. The people dying in the third wave are dying from a supply chain that has become essentially impossible to navigate safely without laboratory equipment. Behind each number in that graph is a person. Each person had a name, a family, a history, a future that was foreclosed. The scale of the loss is genuinely difficult to hold. 100,000 people in 1 year from one primary cause. That is not a statistic. It is a catastrophe. If this story has a point at which it seems to depart from ordinary reality and edge into something that sounds like it was written for a thriller, it is the arrival of Carfentanil, a fentanyl analogue developed in the 1970s for veterinary use, specifically for sedating large animals like elephants and rhinoceroses. Carfentanil is estimated to be approximately 100 times more potent than fentanyl, and roughly 10,000 times more potent than morphine. In the veterinary context, it is administered in carefully measured microdoses under controlled conditions by trained professionals. Its therapeutic index, the gap between an effective dose and a lethal dose, is so narrow that it essentially does not exist for humans. In 2016, Carfentanil began appearing in illicitly manufactured drug supplies in the United States and Canada. The first response from public health officials was, in some cases, genuine disbelief. A quantity of Carfentanil, roughly equivalent to a few grains of salt, could kill multiple people. That is not a metaphor. That is a pharmacological fact. The Carfentanil story is, in some ways, the clearest possible illustration of where the logic of illicitly manufactured synthetic opioids leads when followed to its end. The economic incentive to produce more potent drugs is straightforward. More potent means smaller quantities are required, which means lower production costs, lower transportation risk, and higher profit margins per dose. Each step up in potency is, from the perspective of the producer, an efficiency gain. From the perspective of the end user, each step up in potency is a narrowing of the margin between a functional dose and a lethal one. Carfentanil has essentially no margin at all. A person administering it outside a veterinary setting, without precise scales, without the monitoring, equipment used when large animals are sedated, without the reversal agents available in veterinary practice, is working with a substance where the difference between enough and too much is indistinguishable to the human eye. Wildlife veterinarians who work with Carfentanil routinely wear full protective gear and carry epinephrine and multiple doses of Naloxone on their person, because accidental skin contact with even a small quantity can be dangerous. The idea of this compound appearing in a street drug supply, mixed with unknown cutting agents, pressed into pills of uneven composition, sold to people with no knowledge of what they're consuming, is not a hypothetical worst case. It happened. It killed people. And it illustrated with terrible clarity that the logic of the illicit synthetic opioid market does not have a natural flaw. There is a specific kind of exhaustion that comes from doing the same urgent, necessary, tragic thing over and over again with full awareness that the system creating the need for your work is not changing fast enough. Paramedics, firefighters, police officers, and emergency nurses in communities hit hard by the fentanyl crisis know this exhaustion well. By the late 2010s, many first responders were carrying Naloxone as standard equipment and had administered it dozens or hundreds of times. Some had revived the same individuals repeatedly. The psychological toll was significant. There were early, unfounded fears that fentanyl could harm first responders through skin contact or inhalation, fears that were addressed by the scientific community, but not before causing genuine anxiety among people already working in difficult conditions. The fear was not irrational, given the drug's reputation. It was, however, not supported by the evidence, and its propagation complicated the work of first responders who needed accurate information about actual risks. The compassion fatigue question is one that emergency medical professionals discuss with varying degrees of openness. On one side of the conversation is the genuine human response to repeated trauma, the psychological wear of arriving at scenes of overdose death, of performing resuscitations that succeed and resuscitations that do not, of meeting the same people in the same parking lots in the same crises, of delivering the same terrible news to the same families. On the other side is the professional ethic that insists each person, each call, each body in front of you deserves the same care regardless of how many times you've been here before. Most first responders manage to hold both. They do their jobs, they administer the Naloxone, they initiate CPR, they make the referrals, and then they go home, and some of them do not sleep well, and some of them eventually leave the profession, and some of them find ways to build enough distance between themselves and the weight of what they carry that they can come back tomorrow. The ones who stay, who keep showing up, keep administering Naloxone to people they have revived before, keep treating each case as if it matters because it does, are doing something that deserves to be named clearly. They are holding a line that the system built around them has, in many places, failed to build properly. They deserve better infrastructure. They deserve better resources. They deserve, at a minimum, the acknowledgement that what they are doing is extraordinarily difficult, and that the difficulty is not their failure. The first wave of the opioid epidemic, the prescription drug wave of the late 90s and early 2000s, was disproportionately white, disproportionately rural, and disproportionately middle class. This is not a moral observation. It is a demographic one that shaped the political response. When the faces associated with the crisis were white, and from communities that had political representation, the response from many quarters emphasized treatment, compassion, and the disease model of addiction. Commentators noted with varying degrees of discomfort that the crack cocaine epidemic of the 1980s, which devastated black urban communities, had been met with criminalization, mandatory minimum sentences, and a war on drugs framing that added incarceration to devastation. The fentanyl crisis, touching a broader demographic, produced a more nuanced policy conversation. But the later waves of the crisis, as fentanyl spread into communities of colour, brought their own disparities in treatment access, in policing practices, and in the allocation of resources. The comparison between the crack epidemic and the opioid epidemic became a defining feature of commentary on drug policy in the 2010s, and it is worth handling with care because it contains both genuine insight and the risk of oversimplification. The genuine insight is this: the policy response to a drug crisis is not determined solely by the pharmacology of the drug or the scale of the harm. It is determined, in significant part, by who is being harmed, and whether those people have the political and social capital to demand treatment rather than punishment. The crack epidemic produced mandatory minimum sentences for crack cocaine possession at a ratio of 100:1 compared to powder cocaine, a disparity that was racially disproportionate in its effects and that contributed to mass incarceration in black communities. The opioid epidemic, in its early, whiter phase, produced calls for expanded treatment access and destigmatization. This is not to say that the compassionate response to the opioid epidemic was wrong, it was right, and it saved lives, and it should be the model for responding to all drug crises regardless of the demographics of the affected population. It is to say that the inconsistency is damning, and that a drug policy built on equal application of the compassionate model would have produced dramatically different outcomes from the one we actually had. The fentanyl crisis has, in its later phases, become more racially diverse in its impact. The policy conversation has been slower to catch up. The disparities in treatment access, in who gets referred to rehabilitation rather than incarceration, and in which communities receive overdose prevention resources, these gaps remain. They are documented. They persist. There is a specific object at the centre of the modern fentanyl crisis that does not get discussed enough: the pill press. A pill press is a machine that compresses powder into pill-shaped tablets. In legitimate pharmaceutical manufacturing, they are enormous, precisely calibrated industrial machines that produce pills of exactly uniform composition. In a clandestine drug lab, they can be relatively compact, and they can produce pills that are visually nearly identical to branded medications. Same colour, same shape, same imprint code. The problem is that they cannot, without extraordinary precision and expensive equipment, guarantee uniform distribution of the active ingredient within each pill. This creates what pharmacologists call hotspots, pills where a larger concentration of fentanyl has settled in one portion of the tablet. Two pills pressed in the same batch from the same powder can have wildly different fentanyl content. One might have little effect, the next might be lethal. The pill press entered the illicit drug market in a meaningful way somewhere around 2014 and 2015, when it became clear that the demand for prescription opioids, which tightening regulations were making increasingly difficult to obtain legitimately, could be served by a supply of pills that looked like prescription opioids but were not. The cartels were ideally positioned to meet this demand. They had the fentanyl, they had the distribution networks, and pill presses, it turned out, were not particularly difficult to acquire. They were sold legally for pharmaceutical and supplement manufacturing purposes and could be purchased with relatively minimal scrutiny. The scale of counterfeit pill production that followed was staggering. In 2022, the DEA seized over 50 million counterfeit pills containing fentanyl, pills designed to look like legitimate oxycodone, Xanax and other branded medications. 50 million pills seized in a single year, representing a fraction of what was not seized. Each one of those pills was designed to deceive, to present itself as something it was not, to be indistinguishable from a legitimate product to anyone without laboratory equipment. The implications of this are worth sitting with. The opioid epidemic in its first wave involved people becoming dependent on prescription drugs, real ones, prescribed by real doctors, dispensed by real pharmacies. The fentanyl crisis in its mature form involves people dying from drugs that look like prescription medications but are made by cartels, contain fentanyl instead of what's on the label, and are purchased through social networks and phone apps rather than pharmacies. The two crises are related. Many people in the second crisis started in the first, but they are not the same, and the solutions that would address one do not automatically address the other. When a health crisis arrives faster than the systems designed to address it, the gap between need and capacity becomes a body count. The fentanyl epidemic arrived in a country where addiction treatment was historically underfunded, stigmatized, geographically uneven, and structurally ill-equipped for the volume and complexity of what was coming. Medication-assisted treatment. The use of medications like buprenorphine and methadone to reduce cravings, prevent withdrawal and support recovery is the most evidence-supported approach to opioid use disorder. It is also the most politically contested, most undercovered, and most under-resourced. Buprenorphine, which can be prescribed in a doctor's office, was for years available only to providers who had completed a special waiver training, a regulatory requirement that served more as a barrier than a safeguard. Methadone remains available only through specialized clinics with strict attendance requirements. For someone in rural Ohio without reliable transportation, accessing either treatment was not a realistic option. The history of how addiction treatment has been funded and positioned in American healthcare is, in the most direct terms, a history of stigma made structural. For most of the 20th century, addiction was framed primarily as a moral failing, a problem of will and character rather than a medical condition with neurobiological underpinnings. This framing had enormous practical consequences. It meant that treatment facilities were often built outside mainstream healthcare in standalone programs funded through patchwork grants and patient fees, staffed by counsellors with varying levels of clinical training and subject to zoning restrictions that reflected community attitudes rather than public health needs. When the opioid epidemic arrived and demanded a medical-grade response, the system that existed was not a medical-grade system. The most effective treatment, buprenorphine, was available primarily through the handful of physicians who had completed the DEA's additional training requirement. That requirement was, for years, a significant barrier in communities where the physicians most likely to treat patients with opioid use disorder were already the most overburdened. A rural family practice physician seeing 40 patients a day did not easily find time for the additional training, the additional regulatory compliance, the additional monitoring requirements that came with prescribing a medication that was otherwise safe, effective, and dramatically underutilized. The waiver requirement for buprenorphine was finally eliminated in 2023, a decision supported by evidence and long overdue. But the infrastructure gap it had helped to create did not disappear when the regulation changed. Building the capacity to meet the need requires not just regulatory permission, but resources, training, and a sustained commitment that has not always been matched to the scale of the problem. The system was not ready. In many places, it is still catching up. The fentanyl epidemic and the homelessness crisis in American cities did not arrive separately. They arrived together, feeding each other in ways that made both worse. People experiencing homelessness are at dramatically elevated risk for substance use disorders, not because of any moral failing, but because housing instability, trauma, mental illness, and social isolation are themselves risk factors for addiction, and because the miseries of life without shelter are ones that many people will seek relief from in whatever form is available. Fentanyl, cheap and potent, became the dominant drug in many urban unhoused communities, and for someone sleeping outside without access to clean needles, sterile supplies, or consistent medical care, the risk profile of fentanyl use was exponentially worse than for anyone else. Cities like San Francisco, Seattle, Portland, and Philadelphia saw visible, highly publicized concentrations of fentanyl use in their unhoused populations and found themselves caught between competing imperatives: public order, public health, compassion, and the limits of what any city government can do about a national crisis with local consequences. The political battles that followed were often loud and almost entirely unhelpful to the people living in them. The debate over visible drug use in public spaces became, in many cities, a proxy war between competing visions of social order, between those who saw encampments and open drug use as a failure of compassion, requiring more services, and those who saw them as a failure of order, requiring more enforcement. Neither side was entirely wrong, and the people caught between the arguments continued to die at rates that neither enforcement nor services, in their existing forms, were reducing meaningfully. What research and practice have consistently shown is that the connection between homelessness and substance use disorder is bidirectional and mutually reinforcing in ways that neither problem can be solved while the other is ignored. Providing housing, stable, consistent, non-conditional housing, reduces substance use. Providing substance use treatment reduces the barriers to maintaining housing. The Housing First model, which prioritizes getting people into housing without requiring sobriety as a precondition, has strong evidence behind it and has been implemented successfully in several countries. It is also, in the United States, politically contentious in ways that have limited its adoption. The cities that have made the most visible progress on both homelessness and drug use have generally been the ones willing to deploy multiple strategies simultaneously: housing, treatment, harm reduction, services, and to measure success by outcomes rather than by the political palatability of the approach. These cities are not common. The visible suffering of people who are both homeless and struggling with fentanyl addiction is, in most American cities, not decreasing. It is, in many, increasing. The intersection nobody wanted to acknowledge has become too large and too visible to look away from. Whether that visibility produces policy change or just more argument remains, as of the mid-2020s, genuinely unclear. It would be unfair to tell the story of the fentanyl epidemic without acknowledging the enormous effort that law enforcement has put into addressing it, and equally unfair to pretend that enforcement alone has ever solved a drug crisis. The DEA's operations against fentanyl trafficking have been extensive, targeting cartel distribution networks, pursuing indictments against traffickers, working with international partners to disrupt precursor supply chains, and seizing extraordinary quantities of fentanyl in pill and powder form. In 2023, the DEA reported seizing enough fentanyl to kill every American several times over. And yet, the supply did not diminish meaningfully. The challenge is structural. Fentanyl is so potent that the volume required to supply the demand for it is minuscule by the standards of drug trafficking. Border interdiction, however sophisticated, cannot catch everything that ships in an envelope. Every major study of drug policy that has examined the relationship between enforcement intensity and drug availability has reached a version of the same conclusion. Enforcement is a necessary component of a comprehensive response, and it is not by itself sufficient. The evidence for this is not ideological, it is empirical. Street prices for illicit drugs, which in an effective enforcement environment would be expected to rise as supply is disrupted, have not increased meaningfully despite decades of escalating enforcement spending. Availability, measured by how easy users report it is to obtain drugs, has not decreased. Seizures, as impressive as the numbers are, represent a fraction of the overall supply, and the infrastructure to replace seized product is rebuilt faster than it can be dismantled. This is not a criticism of the individuals doing enforcement work, many of whom are doing extraordinarily difficult and dangerous jobs with genuine professionalism and commitment. It is an observation about the structural economics of a market with essentially unlimited demand and a supply chain that has proved extraordinarily adaptable. The Sinaloa cartel does not respond to a major seizure by shutting down. It responds by adjusting its logistics, changing its routes, modifying its product, and continuing. The cartels have, over decades of operating under enforcement pressure, developed organizational structures specifically designed to absorb losses and continue operating. They are, in this sense, better adapted to a high enforcement environment than the enforcement environment is adapted to them. The question of what to do with this reality is one of the most contested in drug policy. The range of proposed answers runs from more aggressive enforcement to full decriminalization, with most serious analysts landing somewhere in the middle. More enforcement on high-level trafficking, combined with dramatically expanded treatment access, harm reduction, and a reduction in penalties for personal possession and low-level use. None of this is simple. All of it requires political will that has been inconsistently present. There is an approach to addressing drug use that is supported by extensive evidence, endorsed by major public health organizations, practiced successfully in countries around the world, and still deeply controversial in the United States. It is called harm reduction. The core principle is simple. If you cannot immediately end someone's drug use, you can still reduce the harm that drug use causes them. Needle exchange programs reduce HIV and hepatitis, see transmission without increasing drug use. Study after study has confirmed this. Safe consumption sites where people can use drugs under medical supervision have been shown to prevent overdose deaths, connect users to treatment, and reduce emergency room visits. Fentanyl test strips, which allow people to check their supply for the presence of fentanyl before using it, are inexpensive, effective, and were, until recently, illegal in many states because they were classified as drug paraphernalia. The philosophical objection to harm reduction is that it enables drug use. The empirical response is that harm reduction does not increase drug use and does prevent deaths. Let's take fentanyl test strips specifically, because they are a clear, well-studied, low-cost intervention with a straightforward mechanism and documented results. A fentanyl test strip is a small piece of paper originally designed for urine drug testing that can detect the presence of fentanyl in a drug sample when dissolved in water. They cost cents. They take 2 minutes. They tell you, with reasonable accuracy, whether what you're about to use contains fentanyl. Studies have shown that when people receive a positive result, when the test strip tells them fentanyl is present, a significant proportion change their behavior. They use a smaller amount, they use more slowly, they make sure someone else is present, they carry Naloxone. The strip does not stop drug use. It changes how it happens in ways that meaningfully reduce the probability of death. In a rational public health system, distributing fentanyl test strips to anyone who might encounter fentanyl in their drug supply would be an obvious, inexpensive, high-return intervention. In the actual policy environment of the United States, they were classified as drug paraphernalia in most states until a series of legislative changes beginning around 2021. They were illegal not because they increased harm, but because they were associated with drug use, and the political culture of drug policy in America has long treated association with drug use as itself a harm to be prevented, regardless of the empirical consequences of that prevention. This is the philosophical heart of the objection to harm reduction, and it is worth naming clearly. The objection is not primarily about outcomes. It is about what it means to help someone do something you believe they shouldn't be doing. The harm reduction community's response is that the people dying while that debate continues are still dead, and dead is not a better outcome than helped. While the fentanyl crisis has been most acutely felt in the United States and Canada, its reach is global in ways that are still becoming clear. The precursor chemicals that Mexican cartels use to synthesize fentanyl pass through complex international supply chains that implicate multiple countries. Fentanyl and its analogues have appeared in the drug supplies of the United Kingdom, Australia, and parts of Europe, though at lower levels than in North America, in part because heroin remains more available in Europe, and the economic incentive to substitute fentanyl is different. In China, domestic regulation of fentanyl analogues has shifted the chemistry of clandestine manufacturing, but has not stopped it. In parts of Latin America, the cartels that manufacture fentanyl for export to the United States are also reshaping domestic drug markets in ways that public health officials are watching with growing concern. The crisis that most people think of as an American problem is, in its supply chain and its potential reach, a global one, and the world, for the most part, is still working out how to respond to something that moves faster than the institutions designed to contain it. The story of why Europe has, so far, experienced a less severe fentanyl crisis than North America is instructive, because it is not a story about better character or better luck. It is a story about a different drug market structure. Heroin in Europe is primarily sourced from Afghanistan, and the supply chain that delivers it through Central Asia, Iran, Turkey, and the Balkans has been established for decades. It is, by the standards of illicit supply chains, relatively consistent and relatively well understood by the communities that use it. European drug users are accustomed to a heroin supply that does not routinely contain synthetic opioids, and the market infrastructure for counterfeit prescription pills is less developed than in North America. The cultural script around drug use in many European countries also differs. Harm reduction services, including needle exchanges and drug consumption rooms, have been more widely available and less politically contested in countries like the Netherlands, Germany, Switzerland, and Portugal, than they have been in the United States. These differences matter. They do not make Europe immune. They give it a slightly different starting position as fentanyl continues to move. Estonia is worth pausing on at length because it is both a warning and, in a limited sense, an example of what response can look like when it eventually arrives. In the early 2000s, Estonian heroin users encountered fentanyl in their supply, largely because heroin trafficking routes from Russia were disrupted, and synthetic alternatives proved cheaper to produce and far easier to transport across borders that were already being watched. Estonia is a small country, roughly 1.5 million people, with a significant Russian-speaking minority community that was, in the early 2000s, economically marginalized and underserved by public health infrastructure. Fentanyl moved into that community with devastating speed. At the peak of the crisis, Estonia had the highest drug-induced mortality rate in Europe by a margin that was not even close. Whole cohorts of young men in certain communities were dying. The harm reduction programs that existed were overwhelmed. The treatment infrastructure was neither scaled nor positioned to meet the demand. The speed of the transition from heroin to fentanyl left almost no time for adaptation. By the time the public health system understood what it was dealing with, fentanyl had already become the dominant opioid in the supply. Estonia eventually made significant investments in naloxone distribution, in needle exchange expansion, in medication-assisted treatment, in outreach to communities that had been functionally abandoned by mainstream health services. Its overdose death rate declined from its worst years. But the scale of the loss, relative to population, was staggering. And the Estonian experience was available as a case study for any country that chose to look. The North, American epidemic unfolded over the decade that followed Estonia's crisis. Whether decision-makers in the United States and Canada were aware of Estonia's experience and chose not to apply it, or were simply not paying attention to what was happening in a small Baltic state, is a question that does not reflect well on either answer. The United Kingdom presents a more ambiguous picture. British authorities have detected fentanyl and fentanyl analogues in drug samples with increasing frequency. There have been clusters of overdose deaths in Scotland and in parts of England, attributed to fentanyl-contaminated heroin. Scotland, which has the highest drug death rate in Europe, is watching its supply with particular alarm. The UK's broader drug policy environment, politically resistant to harm reduction, slow to expand medication-assisted treatment, operating under a drug strategy that has been criticised by public health experts for prioritising abstinence over evidence, leaves it less well positioned to respond to a fentanyl transition than its public health capacity might otherwise suggest. The window to build the infrastructure before the transition accelerates is a topic of genuine urgency in British public health circles. Whether that urgency will translate into action before the trajectory becomes irreversible is, as of the mid-2020s, genuinely uncertain. Australia, geographically isolated and with strict border controls, has seen relatively little fentanyl in its illicit drug supply to date. Australian public health officials are not complacent. They have watched the North American experience, and they are investing in surveillance and preparation in anticipation of change. But the Australian drug supply, which is dominated by methamphetamine and a heroin market sourced primarily from Southeast Asia, does not yet show the signs of fentanyl displacement that preceded the North American crisis. The global dimension matters because it reframes the question of responsibility. This is not a crisis produced by American weakness or American failure alone. It is a crisis produced by a global chemical and pharmaceutical supply chain, by the economics of illicit drug markets that operate across borders as fluidly as any legitimate business, and by the collective failure of international institutions to build a response that matches the scale and speed of the problem. The cartels are not going to stop because one country gets its policy right. The chemistry is not going to disappear because one bilateral agreement is signed. What is required is a sustained, coordinated international response in chemical regulation, in treatment investment, in harm reduction infrastructure, in the economic development of the communities that the drug trade exploits as both workforce and market. That response does not yet exist at the scale the problem demands. The drug does not know it is supposed to stay inside one country's borders, and neither, unfortunately, does the death toll. Behind every statistic in this story is a family, a parent who found their child, a sibling who got a phone call, a partner who woke up next to someone who was no longer breathing. The grief of overdose loss has its own particular texture, complicated by stigma, by guilt, by the counterfactual thinking that is impossible to avoid, by the question that never fully goes away. Was there something I could have done? Organisations like Grief Recovery, After a Substance Passing, and local chapters of Families for Sensible Drug Policy have documented the experience of overdose bereavement in ways that are both devastating and illuminating. The grief is often disenfranchised, not fully recognised by the culture as the same as other kinds of loss, which means the people experiencing it sometimes do so without the social support that surrounds other deaths. They are sometimes judged. They sometimes judge themselves, and they carry the full weight of a crisis. That was never their fault and never entirely their loved one's fault either, in any simple or satisfying sense. Disenfranchised grief is a clinical term for grief that the social environment does not fully recognise or support. It happens when the circumstances of death carry stigma that the bereaved are expected, implicitly or explicitly, to absorb. Overdose death carries stigma. In surveys of bereaved family members, a significant proportion report that people in their social networks said things after the death about choices, about lifestyle, about what the person should have done differently, that they would never say after a death from cancer or a car accident. The implication that the person who died was responsible for their own death, that they made bad choices, that the tragedy was avoidable if only they had decided differently, is not only medically unsupported given what we know about addiction as a neurobiological condition, it is also an additional wound delivered to people who are already in the worst pain of their lives. Grief is heavy enough without someone handing you a shovel and suggesting you dig the hole yourself. The experience of losing someone to a fentanyl overdose has a specific modern character that is different from earlier forms of overdose loss, and that difference matters. A significant proportion of fentanyl deaths in the current era involve people who did not knowingly take fentanyl. They took a counterfeit pill that looked exactly like the medication they believed they were taking. They used what they thought was cocaine, or methamphetamine, or heroin of the type they had used before, that happened to be adulterated with a synthetic opioid they had no way of detecting. The decision that killed them was not a decision to take fentanyl. It was a decision to take something else, something familiar, something they had taken before without dying, that had been contaminated by a supply chain they could not see and could not test and could not trust. This is a different shape of grief than watching someone struggle with addiction over years and losing them to it eventually. It is the grief of an accident disguised as a choice, and it lands differently on the people left behind, because the narrative of personal responsibility that the culture typically attaches to overdose death does not fit what actually happened, and the bereaved know it does not fit, and they still have to live inside a world that applies it anyway. Parents who have lost children to fentanyl in counterfeit pills describe a very specific kind of rage alongside their grief, not at their child, and not at the addiction, but at the supply chain, at the pill press, at the cartel, at the regulatory failures, at the years of inadequate response that left a drug loose in the world that their child had no way of knowing was in what they took. This rage has been productive in ways that raw grief sometimes is not. It has a target, It has an argument. It has a political ask for test strip access, for supply chain accountability, for pharmaceutical regulation, for the specific concrete changes that might mean the next person's child is not killed by something they could not see coming. Parents who once had no connection to drug policy have become expert advocates, testifying before Congress, meeting with FDA officials, explaining to anyone who will listen exactly how their child died and exactly what could have been done differently. They do this while grieving. They do it because the alternative, the silence, the withdrawal, the private carrying of something that the world seems in many ways designed to help them feel ashamed of, is worse. Action is not a cure for grief, but it is for some people a way to keep existing inside it. Siblings occupy a particular and under-acknowledged position in the landscape of overdose loss. They are in many cases the closest witnesses, the people most likely to have known about the struggle in real time, to have been called at 2 a.m, to have driven to the emergency room, to have had the honest conversations that parents sometimes couldn't have or didn't know to have. And they are, in the aftermath, often rendered secondary. The parents are the primary bereaved. The partner, if there was one, is acknowledged. The sibling is sometimes expected to be the one who holds the parents together, who manages the practical details, who keeps functioning for everyone else's sake, while carrying their own grief that is just as large and just as unasked for. Sibling grief in overdose loss is frequently invisible in the clinical and social literature, and it is not invisible in the lives of the people living it. Partners and spouses who survive an overdose loss carry a particular weight around the circumstances of death, the proximity, the timing, the question of whether they could have intervened, the specific horror of the ordinary moments just before. Someone who woke up next to a person who had died in the night carries that moment in a way that does not have a clean psychological category. The grief is enormous. The guilt is often irrational and also feels completely rational. The path through it is long and requires support that the mental health system is still learning how to provide. None of this suffering is inevitable in the sense that it is beyond prevention. Every one of these people is grieving something that a different set of policy decisions, made years or decades earlier, might have prevented. That is not a guilt assignment. It is a statement about what the stakes of policy actually are, not abstract, not statistical, but this specific parent, this specific sibling, this specific partner, living in the specific wreckage of a loss that a more functional system might have spared them. The debt owed to the people carrying this grief is not payable in settlements or legislation or policy papers, but it is payable, in part, in the sustained, serious, adequately funded effort to make sure the next family does not join them. No serious discussion of the fentanyl crisis is complete without the most contested question in drug policy. What role does the legal status of drugs play in the harm they cause? The argument for decriminalization, reducing criminal penalties for personal drug use, while maintaining prohibitions on trafficking, rests partly on the evidence from Portugal, which decriminalized all personal drug use in 2001 and subsequently saw dramatic reductions in drug-related deaths and HIV transmission. The argument for more radical harm reduction approaches points to the possibility of a regulated legal market that could ensure quality control and eliminate the counterfeit pill problem entirely. The counter-argument is that legal availability could increase use, and that the political and social costs of such a shift are uncertain. The argument for the status quo is harder to make every year as the death toll rises. What the evidence most clearly supports is a shift away from purely criminal approaches toward a public health framework. More treatment, more harm reduction, less incarceration of people who use drugs. The Portuguese experiment has become something of a touchstone in drug policy debates, and it is worth examining what it actually did and did not do. Portugal in 2001 did not legalize drugs. It did not create a regulated market for cocaine or heroin or anything else. What it did was remove criminal penalties for personal possession of all drugs, up to a threshold quantity determined to represent personal use rather than trafficking, and redirect people caught with drugs from the criminal justice system to health-focused panels that could recommend treatment, offer services, and impose administrative sanctions like community service. The change was part of a broader investment in treatment and social services, not just a legal reform in isolation. Drug use did not increase. Drug deaths fell. HIV transmission among people who inject drugs dropped dramatically. The prison population decreased. The public health infrastructure that was built alongside decriminalization had somewhere to send people when they were caught with drugs, and that somewhere was a health service rather than a cell. The results were documented carefully by researchers who were, in many cases, initially skeptical. They expected to find increases in drug use, particularly among young people. They did not find them. What they found instead was that removing the criminal penalty from personal use reduced the barriers to seeking help, that people who were using drugs were more likely to access treatment when doing so did not require admitting to a crime. This is not a counterintuitive finding when you think about it. If the consequence of being honest about your drug use is arrest and prosecution, you're less likely to be honest about your drug use with the doctors and social workers who might help you. Remove that consequence and the conversation becomes possible in ways it was not before. Oregon passed a decriminalization measure in 2020, becoming the first state to decriminalize personal possession of all drugs. The implementation was troubled from the beginning. The treatment and services infrastructure that was supposed to accompany decriminalization was not funded or built at the pace the reform required. The revenue from cannabis taxes that was designated for treatment services moved slowly through bureaucratic channels. In Portland, visible open drug use in public spaces increased, generating significant community distress and a political backlash that eventually produced a partial reversal of the decriminalization measure in 2024. The Oregon experience is frequently cited by critics of decriminalization as proof that the approach does not work. It is more accurately read as a demonstration that decriminalization without adequate concurrent investment in treatment and services is incomplete, and that political will for the legal reform without political will for the funding that makes it functional is not enough. The lesson is not that decriminalization failed in Oregon. The lesson is that half a reform produces half the results, and the half you left out was the part that was supposed to help people. The regulated market argument is more radical and more contested, but it addresses something real. A significant portion of fentanyl deaths occur because people do not know what is in what they are taking. A regulated market, one in which opioids were available through licensed channels, with quality control, standardized dosing, and connection to treatment services, would eliminate the counterfeit pill problem by definition. If you can obtain a pharmaceutical-grade product of known content and potency from a regulated supplier, the counterfeit pill loses its market. This argument has been made, most forcefully in the context of heroin-assisted treatment programs, which have operated successfully in Switzerland, the Netherlands, Canada, and the United Kingdom, providing pharmaceutical heroin to people with long-term addiction who have not responded to other treatments. The outcomes: reduced crime, improved health, sustained engagement with services, have been consistently positive. The political obstacles to expanding this model are enormous. The evidence that it works is also at this point extensive. What all of these approaches share and what distinguishes them from the enforcement-first model that has dominated American drug policy for 50 years is the recognition that the people using drugs are not the problem to be solved. They are the people to be helped. That distinction sounds simple. It has proved in practice extraordinarily difficult to translate into policy. The fentanyl crisis did not happen without human decisions, and some of those decisions were made by physicians, The story of pill mills, clinics that existed primarily to write opioid prescriptions for cash, is well documented. The story of individual physicians who prescribed recklessly, who ignored warning signs, who were paid by pharmaceutical companies to promote their products is also well documented. But it is worth sitting with the more complicated version too. The doctors who were trained, in good faith, that opioids were safer than they turned out to be. The ones who believed the pharmaceutical representatives who told them that long-acting formulations were less addictive. The ones who were caught between a patient in real pain and a system that offered them limited tools to address it. Medical education around opioid prescribing has changed significantly in the past decade. The pendulum has, in some cases, swung hard enough that patients with legitimate chronic pain have found it difficult to access medication. Finding the right calibration remains an ongoing challenge. The pharmaceutical industry's role in the opioid epidemic has been extensively documented in litigation, journalism, and congressional testimony, and the particulars are damning. Purdue Pharma's marketing of OxyContin as less addictive than other opioids, its funding of pain management education programs, its payments to physicians who prescribed its products at high rates, these were not isolated acts of individual misconduct. They were a systematic campaign to reshape prescribing culture in ways that serve the company's financial interests, conducted with full knowledge of the addictive potential of the product being sold. The Sackler family, which owned Purdue Pharma, was eventually required to pay billions in settlements. This was, by most measures, a consequence disproportionate to the scale of harm caused, arrived at 2 decades too late to undo the damage. But the pharmaceutical industry was operating within a regulatory environment that allowed these practices and a medical culture that was, for various reasons, receptive to them. The physicians who prescribed most heavily were not all corrupt or negligent. Many were responding to genuine patient need within a system that had, for decades, told them that pain was undertreated and that modern opioid formulations were the answer. The doctors at the centre of the most egregious pill mill operations were, in many cases, eventually prosecuted. The doctors who were simply doing what their training and their pharmaceutical representatives and their professional societies had told them to do were, in most cases, never held accountable in any formal sense, and many of them are still practicing, still treating pain, still working out what the right approach is in a landscape that has shifted dramatically since they were trained. The patients whose pain is undertreated because prescribers are now frightened of DEA scrutiny, who cannot obtain medications that would allow them to function, are also casualties of this story. They are less visible than the overdose deaths. They are real. If the fentanyl crisis demonstrated anything, it is that synthetic chemistry does not stop producing new compounds just because the existing ones are already killing people at record rates. A class of synthetic opioids called nitazines, developed in the 1950s, never approved for medical use, and largely forgotten for decades, has begun appearing in illicit drug supplies in the United States, Europe, and elsewhere. Some nitazene compounds are estimated to be significantly more potent than fentanyl. They are not easily detected by standard fentanyl test strips. They require higher doses of naloxone to reverse. They are, in other words, a next chapter in a story that public health officials hoped was nearing its resolution. The same dynamics that made fentanyl attractive to illicit manufacturers, potency, small volume, synthetic production, apply to nitazines. The regulatory and public health infrastructure built to respond to fentanyl will need to adapt again. The nitazene story begins in the 1950s in pharmaceutical laboratories that were, like Paul Janssen's, engaged in the search for better opioids. Several nitazene compounds were synthesized and studied, but none were developed for clinical use. Their potency and toxicity profiles raised concerns that were not overcome. The research was published, the compounds were patented in some cases, and then the field moved on. The nitazines sat in the chemical literature for 60 years, largely unremarked. when illicit drug chemists began looking for the next step beyond fentanyl, either because regulators were closing in on fentanyl precursors, or because a more potent product represented a commercial advantage, or simply because the chemistry was there and someone decided to try it, the old nitazene literature was available. Metanitazene, etonitazene, isotonitazene, and related compounds began appearing in toxicology reports in the United States, Canada, and Europe beginning around 2019 and 2020. Metanitazene is estimated to be somewhere between 20 and 100 times more potent than fentanyl. Etonitazene has been described in some studies as up to 1,000 times more potent than morphine. The detection challenge is significant. The testing strips that have become a frontline harm reduction tool for fentanyl do not reliably detect nitazenes. Standard immunoassay drug tests do not detect them. Even hospital toxicology panels may not identify them without specific testing. This means that people who encounter nitazenes in their drug supply, often without knowing it, have fewer tools available to them to identify the risk before it becomes a crisis. The public health infrastructure is, at the moment, running behind. This is, unfortunately, a sentence that has been true throughout the entire history of this story. The chemistry moves faster than the policy. The molecule arrives before the response, and somewhere in the gap, people die. The fentanyl epidemic is not over. As of the mid-2020s, synthetic opioids remain the leading cause of drug overdose deaths in the United States, and the structural conditions that allowed the crisis to develop, undertreated pain, addiction treatment gaps, economic despair, pharmaceutical industry influence, regulatory failure, have not been fully addressed. But something has shifted in the public conversation. The stigma around addiction has decreased, unevenly but measurably. Naloxone is more widely available. Fentanyl test strips have been legalized in more states. Medication-assisted treatment has become slightly more accessible. More people know what fentanyl is, where it comes from, and what it can do than did a decade ago. None of this is enough. But it is not nothing. The people who will determine how this chapter ends are the ones who are alive right now, the researchers, the policymakers, the clinicians, the community organisers, the families still in the middle of it. Paul Janssen built a molecule in 1960 that he intended to reduce suffering. That molecule has caused an almost incalculable amount of it. What we build next, in policy and in medicine, and in the way we treat people who are struggling, will say something about what we learned. The question is whether we learned enough. Let's start with what learning enough would actually look like, because it is not an abstract aspiration. It has specific, practical, measurable components. It looks like a treatment system that can meet people where they are, in rural communities without specialist services, in urban encampments without addresses, in emergency rooms at 2 a.m, in jails and prisons where a significant proportion of people with opioid use disorder are cycling through without receiving treatment that could change their trajectory. It looks like buprenorphine available in every primary care office, every emergency department, every correctional facility in the country, not as a special program requiring extra training and extra registration, but as a standard tool of medical practice, the way antibiotics and blood pressure medications are standard tools of medical practice. It looks like methadone clinics that are not located exclusively in the most stigmatized, least resourced corners of communities, and that do not require daily in-person attendance as a precondition of receiving treatment, and that are not subject to zoning restrictions that treat people seeking addiction treatment as threats to the neighborhood. It looks like harm reduction infrastructure that is funded as public health, rather than tolerated as political compromise. Needle exchanges, fentanyl test strips, naloxone distribution, safe consumption sites. These are not controversial among public health researchers. They are controversial among politicians representing constituencies that associate drug use with moral failure and that associate helping people who use drugs with enabling that failure. The evidence has not resolved this controversy because the controversy is not primarily about evidence. It is about values, about what the community owes to its most vulnerable members, about whether someone struggling with addiction is a person to be helped or a problem to be managed. Every public health intervention that has reduced overdose deaths has been opposed by someone on the grounds that it sends the wrong message. The people who died while the message was being debated did not receive the message. It looks like a pharmaceutical regulatory system that has genuinely learned from OxyContin, that has built the post-market surveillance capacity, the independence from industry funding, the willingness to act on early warning signals that was absent in the 1990s and early 2000s. The FDA has made real changes in how it evaluates opioid medications, in what evidence it requires before approval, in how it monitors safety after approval. Whether those changes are sufficient to prevent the next OxyContin, the next product with a catastrophic long-term safety profile that is not captured in the clinical trials reviewed at approval, is a question that will be answered by the next drug seeking approval and the one after that. The system is better than it was. Better than it was is not the same as good enough. It looks like an honest reckoning with the economic conditions that made the epidemic possible and that continue to sustain it. The communities hit hardest by the opioid epidemic were, in almost every case, communities that had experienced significant economic dislocation, the loss of manufacturing jobs, the collapse of local industries, the specific kind of despair that comes from watching a community lose the thing that organized and gave meaning to its working life over a generation. The relationship between economic conditions and drug use is not deterministic. Most people living in economically devastated communities do not develop opioid use disorder, but it is real and documented and impossible to fully address with medical interventions alone. A pill cannot fix the closure of a factory. Naloxone cannot rebuild a community. Treatment can help individuals. It cannot by itself address the structural conditions that created the demand for the relief that opioids provide. This is the hardest part of the story to sit with, because it implicates things that are enormously difficult to change: the distribution of economic opportunity, the political economy of deindustrialization, the way that communities that have been left behind by the broader economy are also the communities that receive the least investment in the public health and social infrastructure that makes resilience possible. The fentanyl crisis is a public health crisis. It is also a symptom of something larger, something that the medical and pharmaceutical frame captures only partially, something that requires a kind of reckoning that goes well beyond what any single drug policy can accomplish. What we owe the future is the honesty to say all of this plainly, and the commitment to act on it anyway, in the knowledge that acting on what is hard and expensive and politically inconvenient is the minimum that 100,000 deaths per year demands of us. Paul Janssen's molecule is still here. The people who will use it today and tomorrow and the day after are also still here. Some of them are going to need help. The question is whether the help is there when they need it, whether we, in the aggregate, have built the systems and funded the services and changed enough minds and fought through enough political resistance to have something real to offer the next person who walks through the door. The answer right now is sometimes, in some places, more than before, not enough. We are still catching up, and the gap between where we are and where we need to be still has a body count. And so here we are, at the end of a story that began in a small Belgian laboratory in 1960, with a careful man and a careful molecule and the best of intentions. A story that moved through operating rooms and cancer wards and pain clinics and pill mills and cartel laboratories and emergency rooms and living rooms and front porches and parking lots and all the ordinary, unremarkable places where extraordinary suffering tends to quietly arrive. You made it through all of it. 60 years of chemistry and policy and grief and failure and stubborn, imperfect effort laid out while you were supposed to be falling asleep. That says something about you, and I mean that sincerely. Here is what I want you to take with you into sleep tonight. The fentanyl story is not at its core a story about a drug. It is a story about people, about Paul Janssen, who wanted to ease suffering and built something that has caused more of it than he could have imagined. About the surgeons and anesthesiologists who used his molecule with genuine skill and genuine care for decades, before the world outside the operating room even knew its name. About the patients with cancer and chronic pain who needed it and were helped by it. About the patients who were given it when they shouldn't have been, and the physicians who gave it without understanding what they were doing, and the pharmaceutical executives who knew exactly what they were doing and did it anyway. About the chemists and clandestine laboratories who saw in Janssen's molecule not a tool of mercy, but an opportunity, and who built something from it that has killed more than 100,000 people in a single year. About the paramedics who have administered Naloxone so many times they have lost count, and who still show up, and who still care, even when the caring costs them something they can't quite name. About the parents who found their children and then, instead of disappearing into the grief, stood up and walked into committee rooms and said the name out loud until someone with the power to change things finally listened. About the harm reduction workers handing out test strips and clean needles in places that are not safe and not comfortable and not adequately funded, because the alternative to being there is that more people die, and they cannot live with that. About the people in recovery, the ones who made it through, who are still making it through, one day at a time, in a world that does not make it easy and does not always make it possible, but who are here. And about the ones who are not here. The 100,000 in a year, the 3 waves of the graph, the names that the advocates carry into every room, the people who died from something they did not know was in what they took, or from something they knew was dangerous and could not stop, or from pain that the system failed to treat, or from all 3 at once, which is more common than any single narrative can hold. This is not a story with a clean ending, and I'm not going to pretend it has one. The epidemic is not over. The chemistry is still ahead of the policy. The treatment gap is still too wide. The grief is still accumulating. That is true, and it is heavy, and I am not going to set it down lightly. But here is also what is true. Tonight, in cities and small towns and suburbs and rural counties across this country and beyond it, there are people who are alive because someone handed them a Naloxone kit. People who are in recovery because a physician took the extra hour to start them on buprenorphine in an emergency room at 3 a.m. People who are still here because a harm reduction worker handed them a test strip that came back positive and they used less and they woke up the next day. People who are still here for reasons they may not fully understand, in circumstances that could have gone differently and didn't, and who are going to wake up tomorrow and try again. That is not nothing. In a story this dark, that is actually everything. So tonight, as you pull your blankets up and let your eyes close and let the day finally go, maybe hold a quiet thought for all of them. The ones who are still fighting, the ones who are still grieving, the ones who are still working, the ones who are gone. They are all part of this story. And the story is not finished. It is being written right now by people who have not given up in a world that has given them every reason to. Sleep well. You've earned it. And thank you, genuinely,